Hello everyone, this is our Group 8 presentation on sexually transmitted infection and vaginitis.
Complaint: A 19-year-old woman comes in for her annual women's health examination and oral contraception refill. She has no physical complaints. She admits to being sexually active with her male partner of 1 month. History: The patient has been sexually active since the age of 14. At age 15, she contracted chlamydia and received treatment. She did not return for follow-up after her antibiotic treatment. Her preferred method of contraception is combined with oral contraceptives. She does not like to use condoms because they ruin sexual spontaneity. She's allergic to doxycycline. Currently, she does not have medical insurance. Assessment: Her vital signs are a temperature of 98.6, pulse of 80, blood pressure of 100/60, weight of 100 pounds, and height of 5'2". Physical examination reveals external genitalia are without lesions, urethra, visible discharge, or presence of nits or lice. Cervical speculum examination reveals a vaginal vault that is pink with rugae and clear discharge. Cervix is anterior midline and pink without lesions or visible discharge. Swab of the endocervix is sent for gonorrhea and chlamydia screening. Laboratory results are positive for chlamydia but negative for gonorrhea. Urine pregnancy is negative.
Good morning, everyone. My name is Malvin Asibuche. I'm going to be presenting chlamydia patient education. So let's try to define what is chlamydia. Chlamydia is one of the sexually transmitted infection, otherwise known as STI. This is spread through sexual contact, be it vaginal, oral, or anal. This type of STI came from the bacteria called Chlamydia trachomatis. So let's try to discuss the symptoms of chlamydia. The chlamydia's presentation is varied. Some of the patients would present with with symptoms such as vaginal, penile, or anal discharge. Most of the patients would present initially first with burning sensation when urinating, associated with abdominal pain or suprapubic pain. Some would associate it with fever. Female patients would present with sexual intercourse pain. Male patients would present with testicular pain and sometimes associated with scrotal swelling. So how is chlamydia transmitted? Chlamydia, being a sexually transmitted disease, is spread through vaginal intercourse, be it vaginal, oral, or anal, to a person who has a current or active infection. How do you prevent getting chlamydia? Just like any STD, the only way to avoid chlamydia is to not have sex, be it oral, vaginal, or anal, especially if your sexual partner has abnormal discharge, burning sensation in urination, genital rash or a sore, or better yet, just use a condom. So what are the things that you can recommend as a healthcare professional to a person who might be having chlamydia? So the first off is to discuss testing for STI to that person and assure the person that testing is confidential. To never blame a partner. Never assume that your significant other is unfaithful. You or your partner may have both been infected by a former partner or lover. Then be honest with your healthcare provider. Their job is to help you provide treatment and stop STI from spreading. Anything that you will tell them remains confidential.
The CDC reports approximately 2.9 million cases in the U.S. and District of Columbia annually. Chlamydia is underreported due to a large percentage of people having no symptoms. The infection is most common in sexually active young women and men who have sex with men. It may cause inflammation of the cervix in women, inflammation of the urethra and rectum in males and females, and conjunctivitis or pneumonia in newborns. The management plan for chlamydia is as follows: azithromycin 1 gram orally in a single dose, or doxycycline 100 milligrams twice daily for 7 days. Doxycycline is second-hand to azithromycin based on the patient's allergies. If a patient with chlamydia is pregnant and allergic to azithromycin, doxycycline is actually contraindicated in pregnancy, and they are to be treated with erythromycin. Patients being treated for chlamydia should also be treated for gonorrhea, as these two usually go hand in hand. Patients treated for chlamydia are recommended to come back in for a test of cure after 3 weeks of completing therapy if they are a high-risk pregnant patient or if they have not been compliant with their treatment regimen.
What are some different diagnoses that can be used for chlamydia? Symptoms of chlamydia may not become apparent until months after the initial exposure. Likewise, other individuals may not present symptoms at all. Gonorrhea shares similar signs and symptoms as chlamydia infections and typically coexist in many patients' diagnoses with chlamydia. Similarly, Trichomonas vaginalis can mimic clinical symptoms consistent with chlamydia. Differential diagnoses of infectious proctitis, and inflammatory bowel disease may often be mistaken in men who have sex with men. Among women with asymptomatic chlamydia infection, these individuals may present clinically with complicated pelvic inflammatory disease, chronic pelvic pain, infertilities, and history of ectopic pregnancies. Further, bacterial vaginosis is a common infection that affects many women. Individuals reporting frequent infections should be screened for potential STIs. Persons presented with clinical symptoms of an STI infection should undergo testing for other presumptive infections to prevent unwanted complications. What are some complications of chlamydia? A majority of chlamydia infections in women are asymptomatic. The lack of treatment can lead to complications and long-term problems. For women, the cervix and urethra are common anatomic sites of infection, and if left untreated, cervical inflammation can go up into the upper genital tract and cause pelvic inflammatory disease, leading to infertility, future ectopic pregnancies, and chronic pain. Infection of the cervix can also lead to cervicitis, which would have findings of macular purulent endocervical discharge, easily induced endocervical bleeding or edema. As mentioned, the urethra can also occur, and this can lead to dysuria-pyuria syndrome. Women may report that common UTI symptoms, but the UA should show pyuria with no organisms seen on gram stain or in bacterial culture. On occasion, some patients may develop an inflammation of the liver capsule and adjacent peritoneal surfaces as well, called perihepatitis. This is most commonly seen in those who have developed acute pelvic inflammatory disease secondary to chlamydia infection. Although uncommon, rectal infections with chlamydia can occur. This is most common among men who have sex with men, but has been reported in women, usually asymptomatic. An infection in the rectal area can lead to inflammation, proctitis, so rectal site testing should be considered as well. A chlamydia infection while pregnant can also lead to complications. An infection during pregnancy can lead to increased risk of PROM, which is premature delivery and low birth rate newborns.
These are the key points and conclusions on chlamydia. Chlamydia is an infection of the Chlamydia trachomatis bacteria spread through unprotected sexual activity. Chlamydia can often present asymptomatic, but it can still infect partners. Treatment for our patient should include azithromycin 1 gram PO in a single dose, since she is allergic to doxycycline and she is not pregnant. Since we are not sure when she contracted the infection, she will need to contact all known sexual partners within the last 60 days and have them tested and treated. Our patient should be sure to take all the prescribed medication and follow up with her healthcare provider in 3 months for rescreening. All sexual activity should be avoided for 7 days following completion of treatment, and education should include the importance of using condoms to prevent sexually transmitted infections. If left untreated, chlamydia infections can cause long-term complications, including chronic UTIs, pelvic inflammatory disease, infertility, ectopic pregnancies, and chronic pelvic pain. Questions for the audience. Number 1, how are we going to make sure this patient follows up with a primary care physician after treatment? Number 2, for uninsured patients, where can a patient reach for help for treatment? Number 3, what community resources can be beneficial for the patient? Number 4, what are complications if chlamydia is not treated effectively?
Thank you for listening to a Group 8's presentation.